Well, hi. Well, thanks so much for having me today. And so I'm David Bearden. So I'm a pediatric neurologist and neurogeneticist at the University of Rochester in New York, and I've been working on KCNT1 for more than 10 years now, and have been working with the foundation basically since the foundation started, and I'm happy to be kind of leading the scientific advisory board for the foundation. And yeah, so today I'm going to be talking just basically about KCNT1, specifically kind of what families, what information might be useful to families, especially kind of in the first couple of years of your journey with the diagnosis. So these are my disclosures. So I have done some consulting for Biogen and other pharma companies. Most of my funding comes from the National Institute of Health and as well as the United Kingdom Medical Research Council. And I will be discussing off-label use of medications. And what that means is some of the medicines that I'm going to be talking about today, I'll be talking about medicines that are not specifically approved by the FDA for the use of treatment for seizures. And so just be aware that some of the treatments that I'm talking about are not sort of officially approved by the Food and Drug Administration. So this is the outline for the talk. So first, I'm going to just talk about what is KCNT1, talk a little bit about developmental outcomes in KCNT1-related epilepsy, talk about treatment of seizures in KCNT1-related epilepsy, and then talk about treatment of other issues in patients with KCNT1. Because everyone in this group has some form of early onset KCNT1 related epilepsy that is onset in the first year of life, I'm going to be focusing on the early onset KCNT1 related epilepsy. So I'm not going to talk much about late onset KCNT1, such as what's called nocturnal frontal lobe epilepsy, also known as sleep related hypermotor epilepsy. So first, what does KCNT1 do? So KCNT1 is what's called a potassium channel. And what that means is that it regulates electricity in the brain. And potassium is an electrolyte that's important for maintaining kind of normal electrical signals in the brain. One thing that is important to realize is that mutations in KCNT1 don't affect your blood potassium levels at all. So if you measure potassium in the blood, it's generally going to be normal. And the amount of potassium that's in your diet or other electrolytes, like the amount of sodium in your diet, that doesn't actually affect how these channels work, because brain potassium is regulated differently than blood potassium. And KCNT1 really affects the channels that affect the brain potassium channels, but it doesn't, sometimes people get confused and think that it's a disorder of, potassium in the blood, and it doesn't affect that. So what this does is it results in too much excitation and too little inhibition. So we normally have this balance in our brains between things being kind of activated or excited and things being inhibited. And there are neurotransmitters that do that. And so with the KCNT1 channel being overactive, what that does is it means there's too much excitation and not enough inhibition. And when you get that overactive balance, what that causes typically is seizures and also developmental problems. So where is KCNT1 expressed? So it is expressed throughout the body, but the highest levels are in the brain, as well as in the blood vessels, and it's also expressed in the heart. It also has a role in peripheral nerves, but that doesn't seem very important in terms of how the disease actually works. What this does, so KCNT1 is also called the slack channel. And when you have mutations in KCNT1, then you get too much current. So KCNT1 related epilepsy is a disease of too much potassium current going through the channels in the brain. And when you have too much current, what that causes generally is seizures. So in the heart, KCNT1 can also cause arrhythmias, so problems with the normal heart rhythm, although that's rare. And it can cause abnormal blood vessels going from the heart to the lungs, and those are called major aortopulmonary collaterals, or MAPCAs for short. And those are important because they can bleed. And I'll talk more about those later. And those are rare, but probably about 1 out of every 10 children with KCNT1-related early onset epilepsy will have some kind of abnormal blood vessels. So there's 3 main phenotypes associated with KCNT1. So a phenotype just means basically the way that children present. So it's basically what a child looks like or acts like as a result of a mutation. And the 3 main phenotypes are called epilepsy of infancy with migrating focal seizures. This used to be called migrating partial seizures of infancy, or malignant migrating partial seizures of infancy, but it's been renamed now as EIMFS. There's also a late onset form called sleep-related hypermotor epilepsy. This used to be called nocturnal frontal lobe epilepsy, but that's also been renamed periodically. This organization called the International League Against Epilepsy kind of updates the names of various different seizure disorders. And so that's kind of how these things all got renamed. And then you can also have what's called just an epileptic encephalopathy. And that's very similar to EIMFS, but it doesn't meet all the criteria for EIMFS. And often patients with the epileptic encephalopathy might have a type of seizure called infantile spasms. So you can also get these arrhythmias or these vascular abnormalities, but those are less common. So what does this do? What does KCNT1 do? This is just looking at the potassium current. And one of the early studies demonstrated that many patients with the epilepsy of infancy with migrating focal seizures phenotype would have very, very high potassium current, whereas patients with the milder phenotype, the later onset, nocturnal frontal lobe epilepsy, would have sort of a moderate increase in current. And this WT, that stands for wild type, that just means normal KCNT1, so no mutation. And this is kind of just what the channel normally would do if there's not a mutation. It's a little bit more complicated than just the current, but the level of current is important, and this becomes kind of important when we're thinking about possible treatments to try to reduce the current. So how does KCNT1 work from a genetic standpoint? KCNT1 is what's called autosomal dominant. And what that means is you only need 1 copy of the mutation to cause the disease. So if you have 1 mutant copy of KCNT1, you can get epilepsy. And most people who have a KCNT1 mutation will have seizures or epilepsy, although we do know of a couple of people who do carry a KCNT1 mutation and don't have any symptoms, but that seems to be rare. Or very, very rare. So what's the mutation? The mutation is just a change in a gene that causes a clinically important change in the person. So another thing that people will, another name for a mutation is a pathogenic variant, and that just means basically a change in a gene that causes a problem. So KCNT1 can be inherited, especially in patients with the later onset form. But most cases of KCNT1-related epilepsy are what's called de novo. And what that means is it's a new mutation. So basically, when the sperm meets the egg and there's cell division, we have to replicate our DNA. And when that happens, then mutations can be introduced. And that's how most cases of KCNT1 arise. As far as we know, there's no specific risk factors for this. It doesn't seem like it's more common, in older parents. It's not more common in any particular ethnic group. It's not more common, for people who didn't get prenatal care or anything like that. As far as we know, this is just, really kind of a random event that doesn't have any known triggers. So one thing that is kind of an important thing to know about is something called mosaicism. And mosaicism means that some genetic changes can be mosaic. And what that means is that they're not in every cell in the body. They're just in some of the cells, kind of a random subset of cells. And the reason this matters is that you can be a parent with mosaic KCNT1. That is, it's not in your blood. It's just, for example, in your ovaries. And so then you might have multiple children with KCNT1-related epilepsy, even though most KCNT1 is de novo. We do know of some families where the parents were tested, they didn't have the KCNT1 in their blood, and then they had several children with the same KCNT1 related epilepsy change. And the reason for that is because of this phenomenon called gonadal mosaicism. So you can't test specifically for gonadal mosaicism. You can test the parent's blood, but you can't test specifically, the ovaries without like an ovary biopsy, which nobody's going to do. And so the only way really to test for this, if you have one child with KCNT1 related epilepsy, is essentially to do an in utero test of a new baby with essentially by sampling the fluid around the baby and checking for KCNT1 mutations. Alternatively, what some people have chosen to do is to do in vitro fertilization, where you can specifically choose the eggs that don't carry a KCNT1 mutation. And so for some people who have the ability to do that, this can also be an option. But we do recommend, if you have one child with KCNT1 related epilepsy, before you have another child, I would definitely talk to a genetic counselor and figure out all your options for trying to make sure that your next child is not affected. So what's the natural history of KCNT1? So a natural history just means kind of what normally happens without an effective treatment. So typically what happens is that seizures start from a few days after birth, or even the day of first day of life, up to a few months after birth. It can start even as late as 6 months, but it's almost always in the first 6 months of life, although we do have a couple of exceptions. Often there's kind of an initial buildup phase where seizures start becoming more frequent, followed by a stormy phase, where seizures can be very, very hard to control. And then this is often, but not always, especially after the age of around 18 months, followed by a quieter phase in which seizures are easier to control, and some children do achieve seizure freedom during this time. We do sometimes see a resurgence of seizures after puberty in children who go through puberty. Developmental outcomes are generally not very good. So most children with early onset KCNT1 related epilepsy don't walk or talk, although there are, again, there are some exceptions to this, but most of the time developmental outcomes with current treatments are not very good. Sleep-related hypermotor epilepsy is this later onset form. I won't talk too much about it, but it's usually milder. Seizures are easier to control, and the developmental issues are also tend to be milder. So we're going to get into treatment now. So what are the most effective available therapies for KCNT1 related epilepsy? The short answer is that we don't know if any treatment is really, the absolute best, and that treatments really have to be individualized for the individualized patient. So this is just a graph that showed, this is from a paper that our research group published based on KCNT1 registry data, where we basically just asked parents what the most effective therapies were for their children. And what you'll see here is just that, first of all, the success rate for any individual therapy is pretty low. There's no therapy that consistently, is effective more than 50% of the time. Some of the therapies that tended to get the best sort of ratings and effectiveness were the ketogenic diet, as well as a medicine called vigabatrin. The caveat to vigabatrin is that it only works in children who have infantile spasms. So it doesn't work really, I mean, I would say it usually doesn't work if you have other seizure types that are not infantile spasms. But for kids with infantile spasms, vigabatrin can be very helpful. I'll talk a little bit more about quinidine as a potential treatment option. But the sort of take-home message is that nothing works very well, especially in the first 2 years of life. And there's a lot of trial and error. So people often write to me and say, what's the best treatment for KCNT1-related epilepsy? And unfortunately, there's no easy answer. And especially in the first 2 years of life, nothing works very well. So what are the take-home points here? One is that the ketogenic diet appears to be one of the most effective treatments. Vigabatrin appears to be one of the most effective treatments, specifically in infantile spasms. But treatment really has to be based on seizure types, how old the child is, and other comorbidities. So many of the seizure medicines are not approved and don't have safety data in children under the age of 1 year. So in kids who are younger than 1 year, we tend to use a lot of Keppra, which is levetiracetam, as well as phenobarbital, benzodiazepine medications like clonazepam, and then the ketogenic diet can be used in young children as well. But success rates for most individual therapies were pretty low, especially in the first year of life. So what I usually tell people in this first year, which I know you guys are all in this boat, and it's really tough. But the first year is really rough for KCNT1. A lot of people are going back and forth to the hospital, and nothing tends to work very well. And so the important thing is that it does eventually get better. And most children, eventually do have an improvement in seizures, but it's often pretty hard for the first year. And one of the important things I think to emphasize is just not, there's this tendency to just add more and more medicines until the kids are like really, really snowed. And so I would just say it's important to work with your doctor to identify medicines that are sedating but aren't really doing all that much, and try to remove those extra medicines. And sometimes we find that just removing medicines instead of adding medicines ends up having your kids be more awake, and doesn't have a huge effect on seizures sometimes. So I'll talk a little bit about quinidine. So quinidine is a blood pressure or antiarrhythmic medication that in vitro, like in the lab, blocks KCNT1 currents. So we use this a fair amount, several years ago, and some children did have a good response to quinidine, but it was very, very inconsistent. And quinidine is kind of a dangerous drug because it can put you into a life-threatening cardiac arrhythmia. You also need to be able to monitor levels very closely and get EKGs and cardiology evaluations. And so for all these reasons, as well as the fact that it's not clear that it works much better than other medications for most patients. So I don't use quinidine much anymore. I will still use it sometimes in patients that are really that nothing else has worked. But for that reason, I don't use it much anymore. So one question is, why isn't quinidine more effective? One thing is that it doesn't actually get into the brain very well. And it doesn't actually have that high, it doesn't actually bind to KCNT1 very closely. And the other thing is you just get this cardiac toxicity, basically at levels that are, where you don't have great seizure control. So for all these reasons, it's definitely not a first-line treatment, although I will sometimes use it as sort of a last ditch effort if nothing else is working. So what about epilepsy surgery? So unfortunately, epilepsy surgery is not helpful for most patients. There's no kind of single lesion that you, or kind of one single place the seizures are coming from that you can remove with surgery. We do sometimes use what's called a vagal nerve stimulator. This is not a brain surgery, but it's a device that goes into the chest and gives electrical stimuli that can reduce seizures. But we don't have much data on effectiveness for the VNS. Just from talking with patients, some people have seen some improvement. Some people haven't seen much improvement. So I think the jury is still out. Again, I will use a vagal nerve stimulator in my patients if nothing else is working very well. But for most patients, it's not a cure. And there are some newer devices that are used in adults called responsive neurostimulators, but we don't have any data yet in children for those, and they're really only available currently for adults, although that might change in the future. So what about rescue medicines? Rescue medicines are medicines that you give sort of if your child is having a cluster of seizures or a long period of seizures. And this is usually a type of medicine called a benzodiazepine. So for example, Valium or diazepam. And this can be given into the bottom rectally. That's usually with something called Diastat. It can be given nasally, or it can be given via an oral dissolving tablet. That's the most common rescue medicine. Some people will do other things as a rescue, like, for example, giving Keppra through the G-tube or giving Topamax through the G-tube. And usually this will be given for a long seizure or a cluster of seizures going on for more than 3 minutes or more than 5 minutes. But this is individualized for different patients because, some people had the experience where, if my child has a seizure that goes on for 3 minutes, it never stops, before 10 minutes. So we're just going to give it at 3 minutes. Whereas other people are like, well, usually the clusters peter out after 5 minutes. So I don't want to give a rescue because then they're going to be zonked for the rest of the day. So a lot of people do come up with their own sort of individualized treatment plan with their neurologist. So something that comes up is when is the right time to call an ambulance or go to the emergency room? And again, this is going to be highly individualized, and this will also change over time depending on what you feel comfortable doing at home and what equipment you have at home. Often in the first year, if seizures aren't stopping within 2 minutes of giving a rescue medication, then that's kind of indication you might need to call an ambulance or otherwise access emergency services. Or if your child is, desatting, so their oxygen saturation is really low, or if they're turning blue, that's usually an indication you need to access emergency services. I will say it's never a good idea to try to put a seizing child into a car and drive them to the emergency room. So in that scenario, I would just call an ambulance rather than trying to drive with a child seizing in the back seat, because that's not a good idea. So just again, the general principles for treatment of the seizures. There's no single medication that works for everyone. The best treatment regimen is the one that leaves you with manageable seizures and tolerable side effects. A trial of the ketogenic diet is likely worthwhile for pretty much everyone. And it's important to take away medicines that aren't working. So if you're on 6 or 7 medications, that's probably 6 or 7 seizure medicines. That's probably too many. And it's important to work with your doctor in trying to remove medicines that aren't really working. Now, there might be some temporary reason why you need to be on more medications, but if you're on 6 or 7 seizure meds, then trying to simplify your meds is probably important. So how do people monitor their children with KCNT1-related epilepsy? So many people will use a video baby monitor, and that's kind of, I would say, fairly standard. Excuse me. For patients who desaturate during seizures, so their oxygen saturation drops, then an oxygen saturation monitor can be helpful. Now, many people have the experience that their doctors don't want to give them an oxygen sat monitor because it can be very anxiety provoking. Much of the time when the sat monitor alarms, it's just because it's not getting a good signal. So it can really interfere with kind of quality of life and with your ability to sleep. But some kids with KCNT1 just really need a sat monitor and home oxygen at home, because that's the only way to kind of keep them safe. So it's just worthwhile to if you're in that situation where your child always kind of turns blue or desats when they're in the hospital, then this is kind of one of the times where an oxygen saturation monitor can be helpful. So seizure watches are now on the market, and they can be good for patients with convulsions, but they often won't pick up subtle seizures, and many kids with KCNT1 have pretty subtle seizures. So the watch may not work very well, and we just don't have that much data yet, although we are collecting that data. The other thing is the band for the seizure watches is too big to use in most babies. So most of the seizure watches really won't work in infants. We don't have much data on other monitoring devices. You may have seen these. There's like there's a seizure kind of mat that's supposed to detect seizure activity based on movement. There's a sock that you can put on that has been advertised as monitoring O2 sats and things like that. And there's other devices that are kind of coming out. We just don't have much data on these devices, and it's also the market is changing pretty rapidly, so we don't know how well these are going to work in KCNT1. The most data we have is for the watches, and I would expect these other devices are probably going to have similar issues with not being very good at picking up subtle seizures. But I think we'll just have to wait and see how this develops. And often I would say the parents of other kids with KCNT1 are going to be on top of which devices are working well. So this is something where other parents can probably give you some hints as new devices kind of come out. So how about therapies? So in general, regular physical, occupational, and speech therapy are really helpful. Weight bearing, when possible, can be helpful. And because kids with KCNT1 usually can't stand up on their own, using things like a gait trainer, which is basically a device that allows you to do some weight bearing with support, can be helpful, just because that weight bearing is important for bone health, as well as it helps with hip dysplasia. So that's just something to think about, is trying to figure out how you can get some weight on your children. So children often start out very low tone, so hypotonic, and then eventually develop spasticity. And because they start out so low tone, people often don't notice when the spasticity starts, and it ends up being not treated enough. And spasticity can eventually be a big problem. So I would just say, keep an eye on that and bring it to your doctor's attention, because it's something that sometimes gets missed until it's pretty advanced. So in terms of what tests you need, so EEG is important for the initial diagnosis and to help classify infantile spasms or to help differentiate movement disorders. But you don't need to get regular EEGs if things are not changing, so it's not like you need to get an EEG every year if it's not actually affecting your treatment. Usually I would say most kids get an MRI close to the time of diagnosis, but repeating MRIs is usually not helpful because it doesn't really guide treatment at all. We do recommend that all children with KCNT1 get an initial cardiology evaluation to check for heart arrhythmias, as well as to check for these MAPCAs, the pulmonary vascular issues. And then it's also important to screen for bone health and look for osteopenia, and if necessary, work with an endocrinologist to try to help maximize your bone health, because of all the medications, as well as the lack of weight bearing, many kids with KCNT1 do have pretty weak bones, and that puts them at risk for getting fractures, and that can be tough to deal with, but also your child may not be able to tell you, and they won't be able to tell you that they have a fracture. So it may just result in them being in pain or really irritable if they get a fracture. So it's important to try and minimize the chances of that. So we'll talk a little bit more about the MAPCAs. So these occur in about 10% of patients with early onset KCNT1. They usually become symptomatic in the first 2 years of life, but we definitely have some patients where they've developed later. And the first symptom might be coughing up blood. That's called hemoptysis, or it might just be kind of a sudden, sudden development of severe breathing problems. So it's just, and I would say many doctors are not aware of this issue of MAPGAs. And so you may need to, if your child ever coughs up blood or has kind of a sudden deterioration in their breathing, you may need to be the one to advocate and let your doctor know that this is an issue and they need to screen for it. They can sometimes, and there's one particular mutation that seems like it might be more common with MAPGAs, the C1420C to T, they can occur in other mutations as well. And so this is one reason we recommend everyone have an initial cardiology evaluation with an echocardiogram. And you may need further testing with another test called a CT angiogram to get the diagnosis. And these are managed usually by a cardiologist, often with putting little coils to kind of close off the MAPGAs. But you definitely want someone who's familiar with these, because many cardiologists are not familiar with them. So other cardiac issues are uncommon. There is some risk of abnormal heart rhythm, such as long QT or Brugada syndrome, but this appears to be quite rare. And some medications increase this risk, like quinidine or lacosamide. So it's important to see a cardiologist at diagnosis, and if you're taking any medications that increase that risk. So there is this phenomenon called SUDEP, or sudden unexplained death in epilepsy, which is defined as sudden death in a child with epilepsy that's not explained by another known cause. And this is one of the major causes of death in KCNT1. So this is a tough thing to talk about, but it's important because there are things you can do to minimize the chances of that. So one is just optimizing seizure control, also reducing unnecessary sedating medications. There is evidence that having someone else in the room where the child is sleeping, so either having the child sleep in the same room with you, or else having like a home nurse who is keeping an eye on the child overnight, that can reduce the chances of SUDEP. And then I would say monitoring has an unclear benefit, but there is at least some evidence that that having monitoring on your child overnight can be helpful in reducing this risk. Although what the best way of monitoring is, it depends on the child. So other orthopedic issues. So one is hip dysplasia. So this is basically where the hips don't go into the socket properly, and there's underdevelopment of the bones in the hip. This is quite common and often requires a surgery to fix. One thing that's just important to notice is that there are, if you catch it early, there are surgeries that can help and might reduce the chance of having a major surgery later on. So this is something we recommend to just get screened for, by the pediatrician, by the neurologist, and if there's any concerns, just go to see an orthopedist early rather than later, just so that you can have this addressed. Scoliosis, which is curving of the back, can be a major issue, especially in older children. So again, monitor that early through the pediatrician and the neurologist, and just see an orthopedist if this is an issue. And then many children do eventually get contractures, which is kind of chronic tightening of the tendons, which kind of can be uncomfortable. And so sometimes we do need to do what's called a tendon release, just to help kind of loosen up the joints and help prevent contractures. So another thing is that pain or irritability is very common in kids with KCNT1. And this can be because pain from other health issues. So especially, some of the common things are reflux, acid reflux, and other GI issues like constipation. It can also be, sometimes kids can get ear infections or urinary tract infections, and because they can't tell you where things are hurting, it can be hard to figure that out. Kids can also get kidney stones, which can be painful and cause irritability, especially if they're taking Topamax or on the ketogenic diet, which increases the risk for that. So it's important just to be able to screen for that. You can get occult fractures, a fracture in the arm or leg that with minimal trauma that can cause pain or irritability. And then also sometimes we find that kids who have displaced hips or bad hip dysplasia can get this. So it's important to look for all these medical causes if your kids are just super irritable. But once you've ruled out the medical causes, some kids with KCNT1 are just really irritable. And sometimes we do a trial of a medicine called gabapentin, and that can sometimes be helpful just to calm things down and kind of, especially kind of if the pain is keeping your child up at night, gabapentin can be helpful in letting them sleep a little bit. So in terms of feeding, so most kids with KCNT1-related epilepsy are at risk for poor feeding and aspiration. If your child does aspirate a lot, then getting a feeding tube is sometimes really necessary. It's also important if your child is aspirating and having trouble with their breathing, it's important to see a pulmonary specialist to help with lung health and help kind of optimize breathing. A feeding tube can be scary, and a lot of people don't like the idea, but we do find it's very helpful for many people. And in general, because most kids with KCNT1 do have this risk of reflux and aspiration, most kids shouldn't get just a plain isolated G tube. Most kids are going to need either a type of tube called a GJ tube, which actually allows you to feed deeper into the intestine, or else get a G tube along with something called a Nissen fundoplication, which can reduce the chances of reflux and aspiration. So the reason we say not to get an isolated G tube is because that lets you feed, but it doesn't solve the problem of reflux and aspiration. So it's worthwhile just kind of talking with the GI specialist or the person who's thinking about placing a tube about either getting a GJ tube or getting a Nissen fundoplication just to help with those risks. So one question people often ask me is, what should I look for in a neurologist? And I think the key things are that the neurologist should be available to you, willing to learn, and have good communication skills with you, as well as being willing to meet you where you are and compromise with you. It's helpful if all your specialists are at the same place and can communicate easily. It's also helpful to have a neurologist who has experience in treating treatment-resistant epilepsy. But I will say that having someone who has lots of experience with KCNT1 is not really necessary. And, if you're trying to make a choice between like traveling, out of state to see, someone who's, has lots of experience with KCNT1, versus like having just a doctor close to home who like knows you well and can and is willing to learn and listen, I would definitely take the person close to home. Now, sometimes people just don't have the expertise necessary close to home, and they need to travel just to get sort of someone that they feel more comfortable with, and that's certainly reasonable. But I would say just because your doctor hasn't treated a lot of patients with KCNT1, or just because you're the first KCNT1 patient they've treated, that shouldn't be a deal breaker, because that I would say is not kind of nearly as important as some of these other qualities. So what's next? So ideally, what we want to do is to identify new drugs or treatments with less toxicity, better seizure control, and that allow better development. So what's kind of on the table for that? I think conventional seizure medications are not going to get us very far in KCNT1, and we really need therapies that are targeted specifically to address the gene. So there's a number of ways to do this. So one way of doing this is inserting a functional copy of the gene, and that we're not there yet. We're not, I would say, close to that yet. For KCNT1. So that's a ways off, although that might be something that could happen in the future. There's also now technologies you can use to edit the gene and basically sort of clip out the dysfunctional gene and put in a functional gene. And again, that is in early stage research, but that's probably years away. And I don't know if we're going to get there, although there is some kind of promising research with gene editing. So closer to being ready for clinical trials is is gene-targeted therapies that interfere with the production of the KCNT1 gene product. That is, that they reduce the translation of the KCNT1 gene into the KCNT1 channel. And one of the ways that people might do this is with a type of drug called an antisense oligonucleotide. That's what people call an ASO, or another type of treatment called a small interfering RNA, or SIRNA. And these are being developed by a number of different companies. Many of them are in the stage of animal testing. And I think these are the therapies that probably are going to get to clinical trials first. There is also a plan to try to repurpose existing drugs. So we've been working on a drug called carvedilol, which is a blood pressure drug, but it seems to block KCNT1 in the lab. So we'll be doing a trial of carvedilol sometime soon, whenever it gets through the ethics review board. And then there are also companies that are working on small molecules, which are meant to channel, they're meant to block the KCNT1 channel. And those also may be in clinical trials, hopefully soon, although we don't know when. And when I say soon, I mean in the next two or 3 years. So it doesn't mean, like, unfortunately, I think I had been hopeful that we might be having a clinical trial starting next year. But because of some safety concerns that were brought up with the first patients that received an ASO, I think we're probably 2 to 3 years out. Although, I am always, I would love to be surprised and have a company have something ready for us next year. But I think probably many of these therapies are 2 to 3 years out in terms of before we get to clinical trials. So I'll just briefly talk about ASOs, because that is something that I think is going to be probably one of the first things getting into clinical trials. So I'll just very briefly talk about what an ASO is. So an ASO is a synthetic molecule that is designed to bind to a gene product called RNA and reduce gene expression. And so this is, basically, antisense just refers to the orientation of the molecule. And these are basically, oligo means that it's a small molecule, basically. And so the way that ASOs work, so we have DNA that produces RNA, and then RNA gets translated into proteins. And what antisense oligonucleotides do is they bind to RNA and take them out of circulation. And so you get less protein. And this is potentially a good strategy for KCNT1 because the protein is overactive. And so if you make less of it, then hopefully you'll have fewer overactive channels. And I'll skip through this. So ASOs have been around for quite a while, actually, although they really have taken off recently as the technology has gotten better. There's more than 70 ASOs currently in clinical trials. And there's a lot of promise that an ASO might work for KCNT1. So there is, sorry, I'm just going to go through this. So this is just from the mouse model of KCNT1. So there's a KCNT1 mouse that has developmental problems. It has treatment-resistant seizures. And these mice also they tend to die early. If you treat them with an ASO, then their seizures go away. They live a normal lifespan, and their ability to make nests goes back to normal. So this is all kind of promising that an ASO might be able to work in humans. So as several of you may know, there's a doctor named Tim Yu who works at Harvard who made an ASO and treated 2 patients with it. The good news is that it did seem to have an improvement in seizures in both patients. The bad news is that it had really bad side effects, and both patients developed hydrocephalus, which is basically too much fluid in the brain, and one of them died and the other required a shunt. And so that raised some concerns about the safety of ASOs. And so before I move forward with a clinical trial of an ASO, we need to have safety data basically that shows that, a new ASO would not cause those problems, because obviously the first thing we need to do is make sure that the treatments are safe. But it is promising that basically if we can redesign an ASO so it doesn't cause side effects, that we now have pretty good data that it could be an effective treatment in children. And so this is just data basically showing that if you treat KCNT1 mice with an ASO, there's a dose response, and at higher doses, they can live normal lives. And this is just showing basically you can reduce the potassium current back to normal by using an ASO. And you can also reduce the mice nesting behavior back to normal. So again, this is all promising that an ASO might improve seizures, but also improve development. So what can families help do to move towards some of these newer treatments? So one is participating in studies, because this kind of allows us to go to pharmaceutical companies and say, look, we have this really organized patient community. They're super interested in being involved in clinical trials. And this basically gives us clout with companies, because, it's an ultra rare disease, right? So why are companies going to work on this disease? One reason they want to work on this disease is because of the patient community. And if we can go to pharma and say, look, we've got super motivated patients that really want a clinical trial, then that gives us a lot of kind of negotiating power with pharma. So there is a link here. The KCNT1 Epilepsy Foundation has various ways you can get involved. Please sign up for the family contact list, enroll in the registry, enroll in the Invite citizen study, and if you can, donate to the biobank. If you're thinking of having a fundraiser, support the KCNT1 Foundation, because they are really the ones who are kind of championing this disease to pharma and to and to academics, and they're the ones who are really making things happen. So how do you get support if you feel like you need more support? So Sarah, who's on this call at the foundation, can help with kind of getting you support, linking you up with other families. There's also very good Facebook support groups, and in general, if you tag me on the Facebook support groups, I will generally try to respond to any tags, although of course sometimes I don't see them right away. You can also email me, although in general, I am not allowed to sort of give medical advice unless you're my patient. But I am happy to answer kind of general questions, or I'm happy if your doctors want to contact me to kind of give them my suggestions. So I just want to say thanks to everybody on the call and all the other patients who have kind of helped out with the research, and to Sarah for organizing all this, KCNT1 Foundation, which has really just been an incredible resource for everyone with this disease. So this is my team who have been really helpful on the KCNT1 natural history study. And now I will just turn it over to questions.
One question was, can the heart issues that you mentioned develop over time, or is a one-time evaluation enough?
They can develop over time, but in general, so that's actually a really tricky question, because most of the time, I would say just having the one-time evaluation is enough. But we do have, the echocardiogram isn't perfect to pick up these MAPKAs. It's not, it's not the most sensitive test. And so we do find, I would say rarely there are kids who had an echo and the MAPKAs got missed, and then they present later on with kind of coughing up blood or with kind of a sudden change in their respiratory status. And if that happens, we definitely recommend getting reevaluated.
Okay. Another question we have is we're treating with Epidiolex right now. But I was wondering, is there a difference with a little bit of THC and CBD compared to just the CBD?
That's a great question. I would say we don't have good data on that. So there's not, I would say, anything published about that. I will say, just anecdotally, I have had some people find that adding a small amount of THC or CBD oil can be helpful. But we just don't have a lot of data on that. And I also, I feel like this is such a hard disease because different kids just have a totally different reaction to different drugs. So like even with the same mutation, we might have some kids that do much better on like the sort of CBD plus ONFI plus ketogenic diet, and then other kids where that just does nothing. And so I feel like there is a fair amount of trial and error. And so yeah, I know that's not a great answer, but that's just kind of my experience is that some people do have a little bit of benefit from adding the THC, but it's kind of inconsistent.
I actually do have one question also. I know in the beginning you said that there were a few cases that kids were walking or talking. You didn't really specify, but was there anything that led to that, or is it not? There's not really a reasoning behind that.
I will say that so we have definitely a couple kids who had early onset kind of presumed EIMFS that do walk with substantial support, and a couple kids who have said some words. So I know the kids that walk, the two things that I would say I know that their parents attribute their success to. One is just like lots and lots of therapy, early involvement with physical therapy, and just kind of keeping up with therapy and doing kind of early weight bearing with a gait trainer so that their hips, stayed relatively healthy. And so that was one thing, is just kind of therapy and maintaining kind of orthopedic and bone health. And then the other thing was just seizure control. Is that controlling the seizures helped? And that's a tough thing because everybody's trying to control seizures, right? And sometimes some people get lucky and some people don't. But I think those are probably the two things that contribute the most to improve developmental outcomes. One is just early therapies, and two is seizure control. So I think the question was that I mentioned that I do try quinidine sometimes, and when would that time be? Is that the question?
Yes, that's the question.
Okay. So right now, I probably wouldn't try quinidine, and one of the reasons for that is that I think carvedilol is going to be a better option than quinidine, just because it has a stronger binding to the KCNT1 channel, and it's also safer. So right now, because I'm hoping that we're going to start the carvedilol trial later on this year, I probably would not start quinidine, and I would just wait for carvedilol and try that instead.
Okay.
So there's a few other issues with quinidine that I will mention, which also just kind of makes me hesitant. One is that you have to start it in the hospital, and it requires a hospitalization. And so you have to have like basically a neurologist who's willing to admit you to the hospital and do the whole like monitoring protocol. And that can be challenging. The other thing is that there is actually a shortage of quinidine, and so it's actually hard to access in a lot of places. And we've had some of our families that had been on quinidine for years basically had to go off of it because they just couldn't find it anymore. And then the third thing is you have to be able to monitor quinidine levels and get regular EKGs. And some hospitals, some places we just find they just can't measure the levels. So for all those reasons, I'm not doing quinidine right now. I will, I say if the carvedilol trial ends up like not working at all, then and we don't have anything new, like an ASO or other clinical trial, then I'll probably go back to trying quinidine sometimes in those scenarios. But I do just have to tell you that, I got really excited about quinidine when I first started using it because I had good success with the first two kids that I treated it with. But after that, I had a string of patients that didn't do very well, and I had one patient that went into a cardiac arrhythmia, and they had to have their rhythm converted in the hospital. No harm came to them, but it's just as a doctor, when you're prescribing a drug that might kill your patient, it's just it's really it's very anxiety provoking.
Sure.
And I'm sure for the parents, it's anxiety provoking too. I mean, just all the time. So for all those reasons, I'm not excited about doing quinidine right now. Although I probably, if we didn't have anything else and a child was doing very poorly, then I probably would try it again, just with that, obviously with all the appropriate safety stuff in hand.
Okay. So in terms of definitely no quinidine now, but in the meantime, right, we're working with our neurologist. She's very open, trying anything. So we are trying, I think, Divaprolux. I mean, it's just anti-seizure medicines, but is that just our strategy now? Just try what works. If it doesn't, put it away and then kind of go down the list, would you say?
Yeah, I would say in general, that is true. In babies, we have really limited options because there's just not a lot of safety data for many drugs in babies. So, the drugs that people often use are things like Keppra, phenobarb, Topamax, and then and the ketogenic diet, because those are the things that we have safety data on in babies. In older kids, we have been using more. We tend to use a fair amount of the combination of CBD and clobazam, which is Onfi. So and we have, I would say some success with that. And then the keto diet. Recently, I've been using fenfluramine in older kids as well, which is a newer seizure medicine. It's not approved in babies, but in older kids, we've been using fenfluramine with some, I would say, some success. Although nothing works great, right? But so yeah, there is definitely, unfortunately, some aspect of kind of going down the list of possible medications, and using the drugs that that are going to be safe in that particular age group. And the only thing I would say that is sort of a general recommendation is like try the keto diet early, if you can. It certainly doesn't work for everybody, but we've probably had more success with that than with anything else.
Sure, and we're definitely on it already. 3 months, I guess. When it's worked for a while, and now we're beginning to see some stormy phases again, and we're just definitely committed to the keto. Regardless, it's improved much of it. I guess thank you for that. The other question is, we're doing a lot of physical therapy, and when Milena has some good weeks, let's say, she does really well in physical therapy. Like you can see she has some core strength, and then we get in the stormy phase, seizures all the time, and then she's just exhausted. So I just want to, I guess my question is she's gaining some muscle, some control, and then once she has those seizures, is she losing those abilities, and then we're starting from scratch again when she's kind of seizure controlled? Or is she just exhausted and she's she can't move at all? I guess I'm talking about the developmental ability of more movement what do you think
Yeah.
about that?
Yeah, it's a really good question. I don't have kind of a clear answer, but my impression is that the kids don't necessarily permanently lose skills, because we have some kids basically where they've gone through like a stormy phase and they've temporarily lost some skills, but they've, once the seizures got controlled again, they were able to regain those skills, fairly quickly. So I don't think that I don't think that the seizures are causing them to like truly regress. And some of it may just be that that they are like really exhausted. Often, if you're seeing lots and lots of seizures, often they're not really getting meaningful sleep during the night, because if your EEG is really disorganized, that kind of interferes with your ability to kind of get good rest from your sleep, because your sleep pattern is all messed up. And so, my thought is that, if we can control the seizures, I think that a lot of things are going to come back, relatively quickly. Now, the challenge is that it's just really hard to control the seizures, especially like in the first couple of years.
I have one more, since I was just overtaking that. So the new treatments, I think you mentioned they're going, aside from quinidine, this other one. I mean, are we gonna find out when it's working or not working, and then we can tell our neurologist, or how does kind of the comms happen from you guys, right?
Yeah. So once we get the IRB, so I'll just talk about carvedilol first, because that's going to be probably the next trial that's going to happen. And so once that approval comes from the IRB, then we are going to essentially host a webinar for interested providers about kind of how to participate in this trial. And you can be, anywhere in the country and participate in the trial, because it'll just be prescribed by your regular neurologist if they're willing to do that. Yeah, so essentially what we would do, we would make an announcement through the foundation, and then we would just see who's interested, and then we would invite their neurologist to participate in kind of an orientation about kind of, what is this about? What do we have to do to participate? What's the dose? What kind of monitoring do we need, and stuff like that. That's for carvedilol. In terms of other clinical trials, and I'll just say the caveat here is that the pharmaceutical, there are, I think, something like 17 different pharmaceutical companies that are all interested in KCNT1, and there's 3 or 4 that have a drug or a treatment that's in animal trials that they're hoping to get into clinical trials within the next couple of years. And the companies will never they're never going to give like a firm timeline, like we are planning to start this, June of 2025, because then it's bad for their like stock prices, basically, if they give a target and then they don't meet that target. So the companies are always vague about exactly when they're going to have things in clinical trials. So my kind of guessing that these are going to be out within the next 2 years is just based on kind of the degree of interest and knowing kind of where the companies are in terms of their animal testing. But none of them have actually said like, an exact date. So this is definitely kind of a guess on my part. And and I think I'm hoping that a company surprises me and says, you know what, we're ready in 2024. Let's do this. And I really hope that happens. I'm just, I think I'm skeptical that that's going to happen. But because of the interest from a lot of different companies and, various things being in, animal testing at this point, I do think we're looking at probably a 2 to 3 year window before these things get into clinical trials. So in terms of how you find out about clinical trials, the foundation is going to be kind of the number one kind of source of that information. So any companies that want to recruit patients for a trial, they're going to be working with the foundation, and there's going to be kind of an announcement about who they're looking for. The foundation also kind of maintains a list of people who have said, we would be interested in a clinical trial of X drug. And so if you are part of the foundation's kind of contact list and you've answered those questions about your interest in clinical trials, then they would also kind of reach out to you directly and say like, hey, you said you were interested in a clinical trial of an ASO. There's one that's going to be starting, and would you like to hear more information about it?
So if I think we'll wrap it up. We're kind of past the hour. Dr. Bearden, thank you again for taking time on your Saturday once again for our community. We are so deeply grateful for all your dedication to these families and trying to understand this disease.
Yeah, well, thanks so much for joining me. I hope this was helpful. I know I kind of threw a lot of information out there, so hopefully it wasn't too overwhelming. But I think most people have my contact info if you want to ask follow-up questions or anything like that.